Hi everyone, I am Ahmed Jouda, one of the Echo Fellow at St. Michael Hospital. Today I'm going to present a quick case about a bioprosthetic aortic valve infective endocarditis salvage management utilizing an AngioVac. So the question that we're going to answer at the end of this slide, why are we even considering AngioVac when the surgery is a standard care, especially in the left-sided valve infective endocarditis, and why AngioVac is feasible in the mitral more than the aortic valve? And how we can mitigate the major risk factor regarding the left-sided intervention AngioVac, which is the stroke risk factor, and what level of evidence supports our approach, and what is the actual goal when we use AngioVac in this patient, and how we will decide between antibiotic along versus AngioVac and non-surgical candidates, and what eco feature that make you less likely to consider AngioVac. I will start with my case. He's in, to remove this one. Just 1 second. Yep. He's an 81 years old male who presented on 26th of January 2026 with a progressive generalized weakness and acute chronic low back pain and inability to ambulate. In initial clinical concern was for spinal infection process going on. He have a huge past medical history, almost cardiac, and original cardiac amyloidosis, together with heart failure with mildly reduced ejection fraction, coronary artery disease, status post VCI, and LED just before his TAVI was inserted outside of our hospital in 2024, utilizing an accurate Prime XL type of valve with permanent pacemaker after that, because he developed complete heart block post-TAVI, atrial flutter ablation with atrial fibrillation history and history of DVT, pulmonary embolism, monoclonal gammopathy, and hypertension dyslipidemia. So we can find a big list that will really explain why we approach in this patient. This case involved over approximately 3 weeks from suspected infection in the lumbar spine to embolic catastrophe and confirmed prosthetic endocarditis. So starting from 26th of January, lab shows leukocytosis, elevated CRP, and blood culture still was negative initially. Antibiotic was started as to treat the lumbar abscess empirically. An MRI spine was done showing and confirming the epidural abscess with negative blood culture at 30th of January. And 5th of February, procedure was done, intervention guided L5 and S1 biopsy aspiration, which came out to be also culture negative. After that, before the procedure of lumbar spine aspiration, anticoagulation was interrupted and developed acute bilateral limb ischemia and underwent emergent bilateral common femoral artery with a cut down with thrombectomy and left CFA, endarterectomy with patch angioplasty and ligation of the left SVA and right CFA and primary closure. So it was a major and it was emergent limb saving procedure. Despite extensive surgical thrombectomy, the underlying source of embolization remained untreated. So this will highlight the need to address the valve pathology itself. Transthoracic was done, showing in brief, well-seated bioprosthetic aortic valve with a gradient 20. Upon reviewing, the previous echo was done outside the hospital. The gradient used to be 8, the mean gradient for the valve. And previously in January, we have another echo showing the gradient of 41 mean gradient with different sort of volume. But that will alarm us to pay attention more on why the valve is having a high gradient now. And this is one of the images showing the gradient is high, as we mentioned, across the bioprosthetic TAVI aortic valve. In 17th of February, we did the cardiac CT to evaluate the valve setting and possible intervention for that, because we suspect a high gradient and it's a relatively new valve, showing a filling defect, multiple filling defect irregularity attached to the inferior surface and anterior inferior leaflet, with irregular elongated attached to the posterior leaflet also, which highly suspected for infective endocarditis staging process. Still, culture came at 18th of February to be negative, persistently negative at the 4th culture now, 4 out of 4. So 19 February also, we did a TEE, we proceeded for TEE, as been requested by Infective team and a primary physician. We found, yep, this is the mediasophageal at 135 angle, showing a huge mass, lobulated a huge mass attached to the annulus versus the aortic valve, bioprosthetic itself, and it's floating in the ascending aorta. Like modified view. I'll explain if we go showing a thickened and thickened 3 leaflet actually with particularly restricted movement more in the non-coronicus direction one and compared to the right and left direction one. Here again, another view in the ascending aorta showing a floating mass, which can explain the clinical presentation of the patient. No much acceleration of a flow across it. Unfortunately, during the TEE, we couldn't go transgastric to evaluate the gradient across because there was a resistance going in. There is multiple also fibrous-like attached masses to almost all the cusp or the leaflet of the valve. Again, showing a large mass lobulated with high risk of thromboembolism. Is the next plane. Okay, so after that started antibiotics, ceftriaxone and vancomycin, 19 February, to treat infective endocarditis. So we planned for a debulking AngioVac, considering the heart team meeting and the discussion with the patient condition. And so debulking surgery was, debulking intervention was agreed for this patient with cerebral protection using Sentinel. This is a shot from the device that we use, an AngioVac device. You can see it here. I will show it to you later on. This is a right-sided AngioVac device. I couldn't see a particular picture for the left-sided AngioVac device because it's still under study and it's only few case reports about the left-sided. So during the procedure, we use an approach similar to the approach that we are using TAVI procedure in general, the arterial and venous. The arterial, where the suction device was introduced to the ascending aorta, reaching the aortic valve, and the venous was connected to the femoral, and in between them there was a filter and angiosac collection system. And this is like how it looks like, the suction tube. This is what we use, the AngioVac. The others are other alternative for it, and it's used mainly for the right side, not for the left side. This is also how it looks. Pump with the bubble trap and the stop back to the septum. The intraoperative, we tried to prevent Mike to go there and do the procedure, but he insisted to do it. So showing again what we have shown before there was done. This is an intraoperative TEE, a multilobulated mass attached to the leaflet of the bioprosthetic aortic valve that with high risk of thromboembolism, showing coating also of all the leaflet and particular restriction of the non-coronary. The nice view 3D. Can see here. So this is when we try to approach it. As you can see, the catheter, the suction catheter approaching here from the ascending aorta and moving toward the mass, trying to catch the lobulated mass mainly, because the reason for this procedure is debulking, not to like finalize treatment, definitive treatment. You can see it here more clearly. Trying to catch this mass. Unfortunately, fortunately enough, we catch that mass, and the leaflet mobility was improved dramatically after we removed that bulky lobulated mass. At 4th of March, repeated transthoracic images after the debulking AngioVac procedure, showing an aortic valve being gradient of 14, which is acceptable for now. At 1st of April, just yesterday, a transthoracic echo was done, showing a gradient, mean gradient of 11. So this was considered a successful procedure. For summary, in general, 81 years old post-TAVI presented with suspected spinal infection, later on complicated by acute bilateral limb ischemia following interruption for anticoagulation, workup large vegetation on the bioprosthetic aortic valve. Given a prohibitive surgical risk, underwent AngioVac, debulking with good procedure success, treated with intravenous ceftriaxone vancomycin. He would finish as antibiotic at interval. So to take home message and to answer the previous question that we already said before, the gold standard is always the surgery for left-sided valve, especially and particularly in cases where contraindicated or refused by the patient, particularly in persistent bacteremia and recurrent embolization, typically same like our patient. And it functions as a salvage therapy rather than deflex therapy, as we mentioned. Mitral is always preferable, and the masses in the atrial side preferable than the masses in the ventricular side because of two things like flow, the lower flow in the left atrium compared to the ascending aorta flow and the aortic valve, and the control of the catheter itself across the aortic valve versus transeptal function. The stroke risk major limitation, the aortic valve intervention, and most of the robust AngioVac data was on the right-sided endocarditis. So the left-sided, especially the aortic valve endocarditis AngioVac was based on hypothesis and generated rather than practical changes, practice changes. There is no strong evidence supporting that. Like salvage therapy, as we mentioned. The goal for AngioVac is not definitive, as we mentioned, and future may support consideration to include large mobile vegetation, persistent infection, multiple embolic risk factors. Those are the case that I summarize my presentation. It's only a case report, actually, and a few of them only regarding the aortic valve, and it was native. One of them is catastrophic result, fungal infection across AngioVac-assisted debulking with eventually patient died. And he entered multiple embolic complication and septic shock and